Okay, hi everyone. Thanks for joining us today. I am Nicole DeCudros, the Director of Client Business Management here at Arcadia. I'm joined by John O'Neill. He's the Director of Analytics and Information System at WakeMed Key Community Care. And today we're going to talk about how WakeMed is treating diabetes with data, and specifically how they're involved in 2 pilot programs around continuous glucose monitoring. So, hi, John. Good to see you.
No, thanks for having me.
Can you tell us a little bit about WakeMed?
Yeah, WakeMed Key Community Care is an ACO in Raleigh, North Carolina. We have about 200,000 patients that we oversee, and we have 470 primary care physicians and about 1,000 high-value specialists. And we do really well in the ACO field in North Carolina. We're always in the top percentiles for performance on quality measures and cost and all of our payers. So we are small but very kind of well regarded in the state.
And how long have you been in ACO?
2017, I think.
Okay. And just a regular general population, anything specific or unique?
No, mainly commercial population. Most people are, pretty normal. We have a very small Medicare population, but mostly just commercial payers and their patients.
All right, perfect. So I know that you are involved in a pilot program with Abbott Lab and the Libre 2. So could you tell us a little bit about that program around their continuous glucose monitoring system?
Right. So this was a pilot I actually inherited from the previous person in my role. I was told there was a bunch of good data from Abbott Labs looking at their Libre 2 continuing glucose monitoring system. What they did was they went to our providers and they had about 200 of these continuous glucose monitors to hand out to our patient population. They asked doctors to identify them, and they were supposed to sign up and get all these readings, and we were going to give this data to us, and we were supposed to do something with it. That turned out not to be the case. They did not really collect very good data at the time. Some people just didn't turn on the monitor. So we had to really kind of figure out what we were going to do with this pilot. And so we had a large sample, or large sample, about 300 patients who were given the continuous glucose monitors and asked to use it. The pilot project itself only lasted 6 weeks, where they were given free access to the Libre 2 system, and then they would have to start paying for it. So it was a pretty short pilot, and it lasted for about 6 months that they were handing these out.
And they could have either type of diabetes, right?
Yes.
Type 1, type 2?
Or type 2, yes.
Okay.
And so when I was getting the data, I was like, I'm not sure what we can do with this. Abbott Labs is asking us what kind of information they can gather from our study. And so without the direct data from the continuous glucose monitor, we couldn't really make a lot of assumptions based on how well that device was working. But because we had Arcadia, we were able to pull a lot of the historical data on their A1C draws, both pre and post having the cGM installed. And we were able to get actually some really interesting results. So out of the sample of about 300 patients, we were able to find that we had about 104 of the people who received the device had A1C draws within 3 months of receiving it, and also had ones within 6 months of stopping using the device. So we decided to look at this, kind of make a quasi-experiment where we looked at a pre-post A1C and how people with the glucose monitor compared to a control group. Now, again, this study wasn't really set up as this experimental study, so we had to kind of post hoc all this stuff. And fortunately, we had the Foundry database where we could actually do something that we could kind of show some really interesting results by creating a control group after the fact. And how we did that was we took the sample that we had of 104 people who had pre and post A1C draws, and we looked at the demographics, right? And we said, let's aggregate all this information. Then we took the whole sample of WKCC's A1C or diabetic population, and which is about 20,000, 25,000 people. And we asked, we took them and then we randomly sampled that cohort by stratifying on the demographics of the experimental group. So that the two groups had matching demographics, age, race, sex, and one other thing. I'm losing that one. But so now we have these two groups that look very similar, and we can look at their pre and post A1C draws and see how they changed over time. And so what we found was that the people who had got the Libra 2 saw a reduction across the whole population, about 1% of their A1C, while the control group, or the people that we just pulled out from the population, saw about a 0.05.
0.05.
Yeah, 0.05. So this is a very large difference between these two groups. And it appears, by just going off this information, that the people who were given this device did a lot more to reduce their A1C over this the course of this study.
Yeah, knowledge is power, right?
Yeah.
So when you know what your glucose is all the time, you're less likely to eat that sugary meal, or you're more likely to exercise when you know in real time what your glucose level is.
Yeah. And, we didn't see a lot of other kind of variables that matched up to show this kind of same kind of effect. We looked at, did these people close gaps better than the people who are in the control group? No. We try to figure some other things out, but really this is the biggest effect we found. And it's pretty significant. And we, if we could go back in time and design it, we think it'd be a lot more powerful in its analysis, right?
Yeah, because it being a retrospective study, you didn't get to choose the population,
Mm-hmm.
you didn't get to see who would best benefit from that.
Correct.
So now you've got a second study going on.
Yes.
So tell us about that one.
Yeah. So, building off of this study, we wanted to kind of be a little more rigorous in our design. And we were fortunate to get contacted by UNC and Dexcom because they are doing a larger study with Blue Cross Blue Shield using Dexcom's continuous glucose monitor.
And this one is only on type 2 diabetics.
Correct.
Who don't typically qualify for cGM.
Mm-hmm.
So it's really to see, can type 2 diabetics benefit from this if they're actively monitoring their blood sugar? Will they decrease their A1C? Just like the type 1s who are already on the fast-acting insulin. Right now, only insurance will cover cGMs for type 1 on insulin. But you could make the case through data that you can lower your A1C, and you don't need to be on type 2.
Sure. And this population had to be insulin naive, or they couldn't ever have received insulin as a drug. So that was an exclusionary criteria for the population that we pulled.
So that they had never been on insulin before. Okay, perfect.
Mm-hmm. So again, we were fortunate that we have Arcadia and Foundry to get this information. That's how we were able to figure out their medical history, their diagnosis history, and we were able to then pull a population that looked similar to our overall population. So we took the whole population of diabetics with type 2, and we stratified a random sample based on those demographics, so that it looks like the population that WKCC serves in general.
So perfect.
It's pretty much a continuation of what we did with Abbott Lab, but just much more rigorous. So it went through the IRB process at UNC. It's a joint kind of project with UNC's public health department and Dexcom. So what we're doing is really just providing a lot of patient information, their patient histories and their past diagnosis, and then UNC is doing a lot of the data going forward. So and they'll come to us about certain things like A1C draws because they want that from the providers, but they do a bunch of other experiments with them or tests with them at UNC itself.
Excellent. So with all of this data and knowledge, what is WakeMed going to be doing with it in the end?
I think one thing is that we've really been trying to promote more use of cGM in our population with our doctors. We're always looking out for stuff like this where we can participate in something that could really promote this, as a lot of our doctors really believe in it, and they're really excited to work in this kind of stuff. So, that's, we like working it because they give us a bunch of free ones to pass out to our population, but it's also, include us in the research and really kind of putting us out there as a leader in analytics in our field. So,
well, perfect. Well, before we wrap up here, are there any other topics or anything that WakeMed is working on?
Oh, we have a bunch of things. We have, we're doing a lot of, we're jumping into more modeling based off of data. So one thing we really want to get into is understanding our population more. We have 96 practices, and we want to kind of understand what practice looks like other practices that are within our ACO. Right now, we just kind of look at them, whether by organization or size, and that doesn't really get to the population that they're serving. So we want to look at risk and social determinant of health and quality measures, and kind of group these practices together so they can start sharing information among themselves, because we feel that we can provide a lot of analytic support to them, but we're not doctors. We don't work in the clinical field. So we would want them to get together and kind of think, we serve similar populations. What do you do that works? What can we do that might mimic that to help our population better?
Well, perfect. Thank you, John, for joining us today with our bite-sized talk. And does anyone have any questions for John or for myself?
I'd love to hear both of y'all's take on this, but I am curious about the role that communication plays in running these pilots like this. So how are you communicating this information to providers, and why is that important to do?
Yeah, so for this study, the first one, it was someone just kind of picked people up, and it didn't really work very well because some doctors didn't do it, and it wasn't communicated very well. Right. So with the Dexcom program, we've really we started working within our doctor groups that have monthly meetings and kind of promoting this. And we've identified some doctors who really want to work with these kind of devices. And so they're really excited to get this project started. We've identified 700 patients for them already. And that was just in the pilot phase. Now we're actually going to start actively recruiting based on these doctors, and the doctors are, buy into this. They really want the study to understand what the study is doing. They think this device will help their population. So, getting the doctors' buy-in on this is a really important thing for us. So.
Is this going to be published in a medical journal at some point? I would love to see a deeper dive into the data.
Yeah. So, we're working with UNC's public health department, and they are going to, they have a lot more data than just what we have from their medical records. So they're going to do a lot of, the hope is to publish a bunch of it, but it's very early on. We just got IRB approval, so we can't have any publications yet.
All right. Well, thank you, John, so much for joining us.
Thanks
I appreciate it.
Yeah.
Thanks for tuning in to Bite-Sized Insights. Please visit arcadia.io to explore more of these topics, or check out our other podcasts on data science and healthcare.